Organ transplant has provided a new lease on life for many individuals with end organ disease. In fact, the first organ transplant took place in 1950, and it was this moment in medical history that offered the gift of organ transplant and moving forward. In fact, there were many milestones after that. In fact, in the late 80s, you had successful live donors, and after that, in the late 90s, you had Internet Transplant Database, which transformed the platform of organ transplant. Currently, there are almost 100 transplants a day. Now, admittedly, there are a slew of complications that are associated with organ transplant, which is what we're going to discuss for the next 10 minutes. Organ transplant emergencies and their management. And we're going to put specific emphasis on identifying a differential, identifying physical exam findings, and assessing nuances specific to organ transplant. Now, because I have no disclosures, we can simply just jump in with both feet. And my message is this: do not defer your differential. Every transplant patient that presents to your emergency room does not require a septic workup with some sort of gorilla and a call to the transplant surgeon. The next time you see these patients, I want you to think of a differential, start your workup, but also call the transplant surgeon. And you and I must remember the steps of these patients and managing these patients, and not just remembering these steps, but finding the value of each step. So think of infection, rejection, medication, and timing. When it comes to the management of transplant patients, timing is everything. And I would like for you to place these patients into 3 specific categories, and that's early, intermediate, and late. So if your transplant was in the first 30 days, that's early. From end of month 1 to 6 months is intermediate, and latest 6 months and moving forward. Because that alone will provide a map for a great differential and give you and I a place to start with our management and conversation with the transplant surgeon. To put this in context, a patient presents to the emergency room with a fever. What are you treating? Within the first 30 days, we should think surgical site, nosocomial infection, and graft source. It's extremely important for us to remember that the organ donors are often implicated for a source of post-transplant recipient infection. Why is this important? Because the donor viral infections significantly are related to morbidity and mortality, specifically CMV and EBVs. And why is this important? Because we don't treat viruses with antibiotics. So for this patient that presents to the emergency room within the first 30 days of transplant, this needs to be part of conversation, and a part of your questioning is, hey, are you aware of any sort of pathology that the donor had? And you'd be very surprised at when a patient communicates, yes, I am. Timing, ladies and gentlemen, is everything. Remember, these patients we divide into 3 categories: early, intermediate, and late, and that gives us a starting place for our differential. Now let's transition to rejection. Rejection is divided into 3 categories. There is hyperacute, which takes place in minutes. There's acute rejection, which can take place between weeks and months. And then there's chronic rejection, which can take place over years. What is extremely important about rejection is that we understand the rules of rejection, and there are 3 basic rules of rejection. Rule number 1, rejection does not equal organ failure. Rule number 2, rejection can occur in spite of taking medication. And why is this important? Because rejection should always be a part of our differential. So even if they're taking medication, be mindful that rejection is still a part of our differential and a part of our conversation we're going to have with the transplant surgeon. A high amount of patients that have organ transplant have a history of rejection. You have to ask. Ask your patients, Have you had a bout of rejection in the past? Ask the transplant surgeon this as well, because this is extremely important. Because the symptoms that are presenting can give insight to prior or past events of rejection. So if you look at your screen in front of you, you see your liver, your kidney, and your cardiac concerns. So look at these symptoms: malaise, oliguria, fever. With the liver, fever, peripheral edema, abdominal pain, dysrhythmias, palpitations, and fever. These are a list of individuals with organs and rejection. But what is the common theme on each of these categories? It's fever. Which begs the question, when we discuss fever, what is our differential? And I submit to you, ladies and gentlemen, that in the reference to fever, think outside the box. What is your differential for this patient population when it comes to fever? In addition to infection. So what else besides infection? What else could it be? It could be drug effect. It could be malignancy. It could also be hypersensitive reaction, rejection, and thrombosis. This should be part of our thinking when every single patient that we have that presents with organ transplant and a fever, because you don't want to anchor. However, since we are talking about infection, remember that again, timing is everything. So again, placing those patients in 3 different categories of early, intermediate, and late. Early was in the first 30 months, and it's 30 days, big difference. And it's extremely important to remember that within the first month, opportunistic infections are generally absent because the full effect of immunosuppression is not complete. So take a step back. Identify what you are treating. It's not the opportunistic infections in the first 30 days. Again, that's hospitalization, that's surgical site, and the graft source. After your first 30 days, again, we're talking about and categorizing those patients into intermediate, that's first month to 6 months. And that's where the opportunistic infections, that's where those concerns are what we're thinking, with also viral pathology. And don't forget that rejection is associated with febrile episodes as well. So we've discussed the early and the intermediate. So let's transition to causes of infection in the late stage. And again, that is 6 months moving forward. Now, you're concerned of community-acquired catalysts for your infection. And in fact, these patients go into a different category as well. There's the healthy transplant patient. There's also the chronic rejection and the chronic viral infection. I know you're looking and saying, whoa, Chris. How would I possibly know if this transplant patient is a healthy transplant patient that's late or a chronic viral infection? You call their doctor and you ask the questions. It's so very important to have this understanding of these transplant patients so we know what questions to ask, what to look for. So let's talk medication. There's a lot of medication that these patients are taking, and they'll present to the emergency room with many concerns, such as paresthesias, bruising, weight gain, or gingival hyperplasia. These are not merely concerns that are just off the handle, and you have to listen to your patients. Because what they're really saying is, hey, it's the medication that I'm on that I'm having an effect. It's the tacrolimus, it's the macrophenolate. That's where the paresthesias are coming from. And just identifying this, having this conversation with the patient can make adjustments in medication so that their health and outcome are a little bit more convenient and significantly better. So the bruising, the paresthesias, the abdominal discomfort, ask about the medication. Now, admittedly, there was a lot to unpackage with this topic. However, if there's one thing to take home, it's don't forget the steps. Understand that timing is everything. Categorize your patients into 3 different categories for infection, have a differential for your rejection, and ask about their medication. I hope this changes your practice. Thank you very much for your time, and thank you for everything that you do with the patients that we see please provide some evaluation with the QR code and give me feedback on what you see at your shop and what you think of the lecture so that we can change lives together.